like to welcome our first guest on our program today, and a regular guest with us and a speaker at our events, and we're happy to have her back, Robin Gelburd, the President of Fair Health. Robin, good morning.
Good morning.
Hey, good to have you back with us.
It's a pleasure to be back.
Hey Robin, just take a second and just remind our listening audience of Fair Health and your position as one of the leading transparency players in this space. Give a little background to our audience, then we'll dive into this white paper on the opioid crisis.
Of course. So I'm the president of Fair Health. Fair Health is an independent national not-for-profit organization. It was created out of a really sweeping investigation into the New York health insurance industry back in 2009. There were certain conflicts of interest that were identified, and all parties agreed that the matter should be settled and that a new independent not-for-profit should be created that would be tasked with housing a collection of healthcare claims that would be robust and help support data products and analytics for all stakeholders in the healthcare industry. We were also tasked with making a consumer website available for free to consumers to help them understand their costs and expected out-of-pocket expenditures with medical and dental services. And also, as an independent not-for-profit committed to education, our data are also made available for policymaking and research. We have the largest private healthcare claims collection in the country with data for over 150 million covered lives. And I should emphasize that data are de-identified so that it's completely secure and private.
Thank you, Robin. You know, one thing, something you've recently done is a white paper really looking at this opioid crisis that we've really got in the United States. A lot of us talk about it, but you've kind of got a laser focus on it and what is the impact on employers in the privately insured market. So talk a little bit about that. What was your goal in releasing these white papers, and just talk about, you know, what you found out.
That's a great question. So typically we take our billions of claims, now we have over 21 billions of claims, and often shape it into products and analytics as mentioned for others or for others to do research on. Occasionally we feel that given our unique position in the healthcare market, sitting atop this massive amount of data, even though we are not a governmental entity, we really feel privileged and feel a responsibility to provide visibility into that claims collection. So when there are matters of national importance that are really in the public conversation and squarely in the spotlight, to the extent we feel that our data could shed some light on that discussion, then we basically start looking into that ocean of claims to try to provide a necessary window into what we are seeing. Obviously, the opioid crisis has been top of mind of late. It really is impacting so many different corners of our country. So what we did was we did an initial white paper looking at data from 2007 to 2014 and isolated those claims that indicated there was an opioid dependence or an opioid abuse diagnosis. And we found some concerning things. We found that in that time frame, claims with one or the other of that diagnosis rose over 3,200%.
Wow.
We also found that we also looked at, for example, heroin overdose diagnosis. That rose over 500% in that same period. And then there were some, a number of other interesting findings that really caught the attention of the country. It really actually almost went viral in the sense that the findings have appeared really in hundreds and hundreds of outlets. And I think it's because what you mentioned in your intro, that this was a window into the private health insurance market. These are claims from people who are employed, who are sitting in offices next to you in the adjoining cubicle, or students who are in college lecture halls sitting next to your children or your neighbor's children, or sitting next to you on the soccer field. These are people who are part and parcel of our community.
You know, Robin, it's interesting because in the news down here in Atlanta recently has been this heroin problem in suburbia here in Atlanta, very affluent neighborhoods in greater Atlanta area, and that's really what you're talking about. These are middle class to upper middle class families, and and they have insurance and they have coverage, and this is the epidemic that's spreading, both prescription and the heroin usage. Correct?
That's absolutely right. From the period 2009 to 2014, in fact, 78% of heroin overdoses were diagnosed in the age group of 19 to 35 years of age. And what people are finding is that some of these individuals who are using heroin are ones who were previously using prescription drugs to combat pain, various types of opioid-related prescriptions. And when those prescriptions then expire, heroin, they're finding, is a much cheaper alternative. And or there are prescriptions in households that are going unused by the intended user and are finding, their way to others who then become addicted and then turn to heroin as a result. So you're correct. This is happening in the corners of suburbia with, many college-age children or young people who are entering the workforce, and it is one of paramount concern.
Yeah, it is. What of your findings really surprised you when you kind of dug down into this? What surprised you?
Well, a number of things surprised us. One is that we are all connected to this crisis, in that when you look at, for example, the second white paper, if you think about it, in the first, where we looked in the aggregate how many services were being provided and looked at age and gender differences, that was sort of the first ocean of claims that we sort of peered into. Then we really said in the second, let's take that glass bottom boat out there on the ocean and look at the specific procedures and services being accessed by this population and at what cost. And what surprised us, not really surprised us, but we think should be noted, is that the huge difference between the costs associated with someone who is insured, who has an opioid abuse or dependence diagnosis, and then the general pool of insured individuals in our repository. So, for example, for charges, when you think about what kind of billed charges, if you look at an individual with that diagnosis over the course of a year, it went up dramatically. There's over 1,000% difference in the aggregate charges from 2011 to 2015. But for 1 year alone, it would be 63,000 versus 11,000 for someone without that diagnosis. Likewise, for what insurance companies are paying out, they're paying out $16,000 more per individual if you have an opioid abuse or dependence diagnosis. What that means and why we're all connected, almost like an aspen forest, if you will, all interconnected, under the ground with our roots. The insurance industry, we all have these interdependencies that will factor into premiums and other costs that have to be borne by everyone at a macro level in the healthcare system. That was one interesting finding. One other really fascinating finding is those people with an opioid abuse diagnosis, which is considered less serious on the diagnostic scale than the opioid dependence, are presenting more often in the emergency room than those with a dependence diagnosis, who are incurring more costs for office visits and lab tests. Again, what that is showing is an opportunity there for those people presenting in an acute distress state at the emergency room to be steered into more treatment programs like those with an opioid dependence diagnosis, and can start getting some systematic care and attention to their condition. And that, as I said, is an opportunity for the healthcare system to start doing some triage and referrals and making sure that there are sufficient resources for treatment and recovery.
Interesting. Very, very interesting. So, what are what are the lessons that you want an employer or an insurer to kind of learn and take away from this research?
There are a number of things that people can pay attention to. One is, given the growing need for these services, there should be attention paid to the provider networks that are supporting various insurance plans. There should be attention to incorporating into those provider networks those with sufficient levels of expertise to meet those needs. And if you're in more rural areas where it's difficult to amass those kinds of services, there may be some creativity that could be brought to decision making with respect to telehealth and including some other avenues for service. Likewise, you would want the plans to think about what their benefit design is, making sure that they're keeping pace with what the best outcomes are so they don't cut off reimbursement for services that may go beyond a certain limit when it's been proven that extended types of services can have some impact. Obviously, member education, patient education is key. Also creating the appropriate type of referral streams between, as mentioned before, emergency rooms and departments and outpatient substance abuse centers. So there are a number of opportunities presented by the data that can lead to some positive advances.
So what are the and the actions that can be taken as a result of this data? I mean, you touched on some of that. So what are some concrete actions that can be taken as a result of this the data that you're sharing with the market?
Well, I think what can be taken is at the policymaking level, each state is very different in their acceptance of telehealth services, for example. Those are becoming more and more common. So health plans and policymakers in states can start having that conversation about ways in which to enhance and broaden their provider networks to include those, if necessary, to make sure that there's sufficient access for members to get the treatment that they need. As I said, then there is ways in which that plan documents can make very clear what the benefits are in the different insurance plans that allow consumers to shape treatment and recovery options to make sure that they're both getting well clinically as well as making sure that financially they are managing those expenses. And obviously there are huge opportunities in terms of education, both in terms of member materials and information and access to resources that plans can provide, as well as really incorporating into the educational system the kinds of programs I know that my sons had with respect to the DARE program regarding tobacco use, which were quite successful. So given that we're seeing 19 to 35-year-olds really being profoundly hit by this crisis, we have to start earlier and get them before they enter into that statistic.
Yeah. When did you reveal that, particularly the second white paper, when did you release that?
That was in September. I think what happened was when we released the first one that became public August 1st, there was such tremendous interest both nationally and internationally, and we're really delighted. One of the things that came out of this, and it goes to what we hoped, some concrete actions, we were invited to the National Press Club earlier this week. It was a symposium sponsored by the Poynter Institute to really meet with journalists and provide them with resources and information and data that can bring nuance and texture to the coverage of this opioid crisis. Yes, it is, really striking the chord emotionally for many as we see these horrific pictures and hear these horrific stories. But then what there was an effort to do was to sort of elevate it more to that macro level, and how do we start dealing with it systemically, and how can journalists be armed with understanding all the complexities of this. And then the white paper led to a meeting for us with the White House Office on Drug Policy, again, to really understand more deeply what these statistics were demonstrating and really how to grab a hold of these findings and translate them into some policy initiatives.
Yeah, you just answered my question, because I was going to ask you what was the reaction to this white paper, and I think did a nice job of really highlighting, because you're right. I mean, we're all aware of this, and it's all top of mind. So you're bringing some concrete details into the market and some substantiation of the depth of this problem and some steps that we need to be taking to address it. And it's really good work, Robin. I really appreciate you sharing that with us today on this program. I want to give you the opportunity to kind of leave our audience with a few takeaways around this, please.
Well, I think the takeaway, again, is to feel compassion, and we're not saying to tamp down the emotional tug this story has for us as we think about those people on the soccer field next to us or in the lecture halls of the universities or in the cubicles next to us or office next to us, but also recognize at a policy level and at a financial level at a systemic level, as I said, we are all connected to this, and we all have a part to play in trying to get our arms around this epidemic and think about ways in which we can organize the healthcare system meaningfully to really start bending the curve of this emerging and continuously growing crisis.
Yeah, I couldn't agree more. Robin, where can listeners find these white papers? Where can they go to find
well, thank you for asking. Yes, they can go to our website at fairhealth.org, and they are available for free on the site there.
Robin, listen, it's great to have you on the program as always. You always share some really relevant, timely, and important information, and thank you for doing so today. You have a great weekend, and we'll talk to you again real soon.
Thank you so much. Bye-bye now.